Hello, everyone. I'm really honored to be here today to talk to you about this topic, transplantation for myelodysplastic syndromes, who, when, and how. I am Nandita Khera, an associate professor at Mayo Clinic, Arizona, and my co-presenter will be Dr. Linda Burns, senior scientific director at CIBMTR, Milwaukee. We will be presenting on behalf of the CIBMTR, which is the Bone Marrow Transplant Registry, and as co-chairs for a task force on evidence into practice for BMT Clinical Trials Network, an organization that conducts clinical trials in the space of cellular therapy. Thank you so much to the Aplastic Anemia MDS Foundation for inviting us to do this. We have no disclosures. For the next few minutes, we'll talk to you about myelodysplastic syndromes and the role of allogeneic hematopoietic cell transplantation for MDS. We will highlight the transplant process, describe the results of an observational study that was recently published along with a recent clinical trial, and we will list some potential challenges for patients and providers to get to transplant. So let's start with what is MDS and how common is it? It is a group of bone marrow stem cell cancers that is defined by low blood counts, marrow dysplasia, which means abnormal looking cells when the pathologist looks at the slide under a microscope, and chromosome changes. It is characterized by need for transfusions and risk for infections due to low blood counts. It's a spectrum of disorders and that can range from low intensity or low risk to intermediate risk and to very high risk disease. And the risk that there is of it evolving into a full-blown acute leukemia or blood cancer. And usually how we determine risks is by looking at how many cell lines are affected, if it's just the red blood cells, just the white blood cells, or platelets, or a combination, what kind of genetic markers are there, and we look at the number of abnormal cells or so-called blasts in the bone marrow biopsy. This is mostly diagnosed in patients in their 70s, and it's quite uncommon in younger age groups, especially before 50 years of age. Overall, it's a rare disease with only about 10,000 patients diagnosed every year in the United States as compared to about 325,000 with breast cancer. So how do we treat MDS? As you can imagine, since it's a spectrum of risk, the treatment strategies are very varied too. They can range from supportive care, which would include transfusions or use of growth factors to improve blood counts. Mostly they are used in low-risk patients, sometimes in high-risk patients, especially if they are frail and cannot undergo any intense treatments. Then there are disease-modifying treatments, or the so-called gentle chemotherapies, which may change how the disease progresses. In the sense, they may delay the progression of the disease, but ultimately are not curative. The only potentially curative therapy that we have available for MDS at this time is hematopoietic cell transplantation, also known as blood or marrow transplant or stem cell transplant, which uses someone else's stem cells. And so it's the allogeneic stem cell transplant. So how do we decide what treatment approach is best for a patient? There's four main factors that we consider or that go into the shared decision-making with the patient and family in trying to decide what's the best for a patient. The first is patient age and fitness. The second is MDS risk category. So in general, the low-risk patients are treated with supportive care or sometimes the gentle chemotherapies, whereas the high-risk patients, usually we would prefer to take them to transplant sooner rather than later. We have to weigh the risks and benefits of treatment options, especially in the context of each patient individually. And we have to obviously respect the patient's goals and wishes in terms of how they would want to live their life, how much importance they lay on quality of life, and so forth. This is where a little bit of subjectivity comes in too, because the same decisions could be made differently if a patient is being seen at a community site or a community practice versus an academic practice. So let's talk about what is an allogeneic hematopoietic cell transplant or stem cell transplant. As we mentioned, that it is a transplant where you get someone else's cells. So the patient receives healthy stem cells or what are called a graft donated by somebody else. This somebody else can be a family member, can be a sibling, can be children, can be parent. It can be someone unrelated to them that we can find through a registry, or it can be blood collected from the umbilical cord when the baby is born. The rationale for doing these transplants is that we hope that these new stem cells will grow and replace the damaged stem cells of the patient. And we also believe that the new immune system that can help then destroy any disease cells in patient's body, and this is what we call graft versus tumor effect, which is responsible for the potential cure with transplant. So let's talk about what are the risks and benefits of transplant. It is a very complicated procedure. And so there are definitely risks involved, and they can be risk of early complications, such as infections, organ damage, and graft versus host disease, which is a complication when the cells that we provide from the donor to the patient, they start attacking the patient's body because they recognize it as an enemy. There can be later complications such as ongoing infections, organ damage, and chronic GVHD, which is the long-term damage that can happen from the donor stem cells to the host. And all of these can be important because they are associated with poor quality of life in the long term. And then, as I mentioned, it's a potential cure, meaning it's not 100%, that even after a transplant, the MDS can still come back. Now, the chances of that happening are probably much, much lower than if we did not transplant the patient, but they're still there. And our field is working very stringently to try and minimize those chances so that it can become a 100% cure. And then there are other late complications, such as the risk for second cancers because of the transplant process. And more than the medical complications, there are also financial aspects. So it's a very expensive, logistically intense, complicated procedure. Patients may have to relocate to be near the transplant center for a period of time. And so all of these decisions, all of these factors will be affecting the decision to move to transplant. The benefits are obviously, it's a potential cure, especially for our patients with high-risk MDS. And also, it is a strategy that we use very commonly for patients who stop responding or are continuing to progress on various non-transplant treatments. So the question then comes up is whether we should transplant or not. So for that, recently we had this biologic assignment trial of a reduced intensity hematopoietic cell transplantation based on donor availability in patients 50 to 75 years of age with high-risk MDS that was published in Journal of Clinical Oncology. So let's talk about what do we mean by a biologic assignment trial. You may have heard randomized control trial, which is the more commonly used treatment or trial strategy in which we have a 50% chance of ending up on a treatment arm versus no treatment arm. In this case, it was based on the availability of a matched related or unrelated donor based on a search done up to 90 days after enrollment. So if somebody had a donor, then they ended up on the treatment arm, which is the donor arm, where they got a transplant using lower intensity conditioning regimen within 6 months. And if they didn't have a donor, then they received hypomethylating agent, which is the gentle chemotherapy, as I mentioned, or best supportive care, as was decided by their doctor. The inclusion criteria for this study included patients with higher risk MDS, 50 to 75 years of age. Any prior therapy was allowed, but no prior lived for 3 years overall. And secondary outcomes looked at how many patients lived for 3 years without leukemia, so-called leukemia-free survival, quality of life, and cost effectiveness. So in terms of the results of the study, what we found was that patients who had or who were on a donor arm did better than patients who were on the no donor arm. So on the left is the graph showing patients who lived for 3 years and about 48% on the donor arm, and it was about 27% on the no donor arm at 3 years, and this was considered to be significant. In terms of patients who lived for 3 years without leukemia, again, there was an improvement for the outcomes for patients on the donor arm with 36% survival versus 21% on the no donor arm. And interestingly, the quality of life that was measured by various instruments for quality of life was the same for all patients, whether they were on the donor arm or the no donor arm at enrollment or at multiple time points after enrollment. So to conclude, the study showed that among patients with higher risk MDS, age 50 to 75, having a suitable matched related or unrelated donor transplant leads to improved outcomes with similar quality of life. And therefore, transplants should be considered as an integral part of MDS treatment planning for such patients. And for this, we would want that a referral for transplant consult should happen as early as possible, even at diagnosis, for things to move forward if the patient is found to be an appropriate candidate for transplant.
Thank you very much, Dr. Khera. This is Dr. Burns, and I thought we would have a chance to dive a little bit deeper into some of the points that you raised. You told us the patients are typically in their 70s when they're diagnosed with MDS, but would a patient have any symptoms? How do they find out that they actually have this disease?
So in general, these patients would find out by a blood test that would be done for another reason. So it could be at the time of their annual visit. It could be if they are having any sort of surgery or a procedure, and that's when they're found to have abnormal counts, which then needs to be looked into, and that's how we will find MDS if they get a bone marrow biopsy. Now, sometimes patients will have some symptoms, especially if they are very anemic. So fatigue is, I think, the commonest symptom that we will see. Sometimes they may have frequent infections or bleeding or bruising as their presenting feature if the white blood cells or platelets are being affected, respectively. So I would say, in general, most of the patients that I see have this found as an incidental finding based on blood work done for another reason.
Okay. So again, coming back to age, typically in their 70s, though can occur, the study that you showed us was 50 to 75 years of age, but this is a population where many patients would have Medicare for insurance. Can you tell us a little bit about Medicare coverage? You mentioned that this was a very expensive procedure. So does Medicare cover the cost of transplant for MDS?
That's a great question, Dr. Burns. So in 2010, Center for Medicare and Medicaid decided that they didn't have enough data to say that transplant was an effective treatment for older patients with Medicare. So they came up with this program called Coverage with Evidence Development, whereby they decided that they would cover the transplant costs if the patient was enrolled on an observational study that would then allow us to look in a more scientific way the outcomes. And so actually the results of that observational study that was conducted by our bone marrow transplant registry were published a couple years back. And what they showed was that patients who were above 65 years of age did quite comparable to patients who were lower age, 55 to 65. And so based on that, we have a good signal that patients, even older patients, do okay. But again, that was not enough because it was still an observational study. So I'm glad to say that the results of this trial have recently been submitted to CMS, and we are hoping that they will come back to us with providing uniform coverage without the need for enrolling on the CED program in future for transplant.
Great. So CMS is the Centers for Medicare and Medicaid.
Mm-hmm.
Yeah. So they're the ones that administer the Medicare program. So it appears that patients should seek consultation at a transplant center. And I know the transplant centers typically will work with the patient and with their insurers to make sure that coverage is there. So this is really great news that these study results are being used, and hopefully then we'll have coverage forevermore by Medicare. Let's hope. We often think about patients that undergo transplant. We worry about quality of life. It's a complex procedure, as you said. There's potential complications. And that seemed to be really an important aspect of the study that you showed us. Were you surprised that the quality of life was similar, whether or not patients were in the donor arm and had a transplant, or in the no donor arm and had more gentle therapies?
I have to say yes, I was, because I would have expected a more fluctuating course with transplants. So, as you would know that for our transplant patients, the quality of life goes down a lot right after transplant, especially when you look at the short-term day 100 or 6-month kind of outcomes, and then usually by 1 year and after 1 year is when they start approaching more like about 70-80% of their baseline quality of life. So I would have expected to see more of a dip and then an improvement. And alternatively, in the no donor arm, I would have expected to see more like they started off good, but then they had a slow decline because as the non-transplant treatments stop working, as their disease progresses, they become more anemic, that it would actually fall. However, what the study showed was that they were at all these time points. So they looked at enrollment, they looked at 6 months, 1 year, 18 months, and so forth. And what they showed was that the quality of life actually was quite comparable both in the donor and no donor arm, which was a surprise, but also a good thing because I know that a lot of patients will put a lot of emphasis on quality of life, not just the quantity, with such a high risk procedure otherwise. So that was a good data that we were able to get from this study.
Great, thank you. And so I also noticed that in the study that you showed us, that from the time that the patient was enrolled, there were up to 90 days to look for a match-related or matched unrelated donor. And what we mean by matched is that the same proteins on the cell surface. This is called human leukocyte antigen, or HLA matching. What if a patient at 90 days hasn't found a match-related or unrelated donor? Does that mean they can't have a transplant? Are there other options for donors?
Yeah, I think this study raised this very important question. Is for the sake of the study, they only looked at these two groups, the matched related or unrelated donor. However, again, as you would know, and some of our patients would know also, that our field of transplant has evolved quite a lot. There's a lot of research going on in this area, and there is an increasing use of what we call alternative donor sources, which means using cord blood or using a half match donor, which again, kids can be a half match, sometimes siblings in 50% cases can be a half match, or parents if it's a younger patient with older parents. So there are, I would say that right now our field is at a point where anyone who needs a transplant has a good chance that they will find an optimal donor. It may not be a full match, but they can still be used for transplant. And there are studies, not just in MDS, but in other disease areas that have shown that the outcomes with, say, a half match transplant or a mismatch transplant may be slightly lower than the matched related or unrelated, but are overall, they are still very good possible sources for such patients who do not have this kind of an option. So I'm hopeful that we will continue to study this specifically for MDS, and that we will be able to show that use of alternative donors is going to make this option open for anyone who needs a transplant for MDS.
Great, that's great news. So the take home is that not having a match-related, unrelated donor doesn't mean that you can't have a transplant. There's
Exactly.
many options now for donors. So that's really great news for our patients.
Yes, exactly. So with that, actually, I will move on to request you, Dr. Burns, to cover the next part of the talk, which is talking a little bit about the process of transplant and what can U.S. patients do to make it have a successful outcome.
Yeah, great. Thanks very much. So this is a slide that I'm going to walk through that really explains what the transplant process would be for you as a patient. Typically, you would be diagnosed by your treating doctor. This would be a hematologist or oncologist doctor in your local community. You might actually see your primary care physician. As Dr. Khera said, often this is diagnosed by just having a routine physical. And you might be referred then to a hematologist or oncologist who would review your case with you and make a referral to a transplant center for consultation. And that means that the transplant doctor and team, is typically multiple team members, would see you at the transplant center and again, go over your case, go over your particular case of MDS, because as Dr. Khera noted, that this is a spectrum of diseases from low risk to higher risk. And with a shared decision-making approach, help you, your family, your caregiver, and your community physicians work together as a team to decide if transplant is the best option for you. If it is, then as we mentioned, then you would need to have a donor, an allogeneic donor. And I'm delighted to tell you that the National Marrow Donor Program, Be the Match, has been working with community hematologists and oncologists at the time of first diagnosis to help provide free human leukocyte antigen or HLA testing for donors. So it can even be done at diagnosis, or your transplant center, when you're seen there for consultation, can begin that process. It's not up to you to find a donor. You need to just focus on yourself and your family and let the transplant center team help you. They will do the searching for a donor. Again, that might be with a family member. It might be a half-matched donor. It might be a cord blood. It might be an unrelated donor that through the National Marrow Donor Program, Be the Match. If there are several donor options, the transplant team will take a look at your disease, what is the possible donor options, and choose the best donor for you. And then working together again with you and your community physicians, look to see whether or not you need any therapy before coming to transplant to make sure your disease is under good control, and plan that with you for when you would be admitted to the hospital for transplant. But before you would actually go to transplant, there's usually several days, even up to a week perhaps, of a very comprehensive evaluation. And that evaluation means that we look to make sure that your disease is under really good control, because that's our best chance that if you enter into transplant with the smallest amount of disease, it's more likely that the transplant will cure you and the disease will not come back after transplant. But we also want to make sure that you're really healthy, that your heart, your kidneys, your lungs, everything is really working well. And also importantly, that you don't have any infections that might complicate your transplant. So on the next slide, this would be the process that would kind of go along for several weeks to months of you having your transplant. So let's say that you've had your comprehensive evaluation, everything looks good, you're admitted to the hospital. And then typically over those first few days that you're in the hospital, you receive what's called a conditioning regimen or preparative regimen. And you may recall that when Dr. Khera reviewed the study that was performed, it was what's called a reduced intensity. And what that means is that over the past couple decades, that transplanters have learned how to give smaller doses and different types of chemotherapy drugs in combination that can really help suppress your immune system to allow the new cells to grow. But they're not real big doses of therapy, and we can do this without big doses of radiation too. And it's much better tolerated, and that's really important for patients with MDS who are older and who may not tolerate larger doses of conditioning. So your transplant team determines the intensity, how high of doses of conditioning to give you. And then afterwards, on day 0, that's when your new stem cells are given to you, and it really looks kind of like a blood transfusion. You will have had a catheter or line inserted into a large vein earlier in your transplant course, and those cells are given through that catheter. And you're typically also given medications to help prevent infections, to give medications to help prevent that severe graft versus host disease that Dr. Khera mentioned. And then we start watching and waiting for your new stem cells to grow. And how we know that they're growing is that we can see that by blood counts. And typically the white cells grow in first, then the red cells, and then later those platelets. This is where your team will work very hard to support you, to make sure that you're having everything that you need to help you remain strong. You often have physical therapists working with you, nutritionists. They will help you gradually recover and transition to, if needed, all of your oral medications, that you're able to do all of your activities that would be needed for daily living, and be strong enough that once you're discharged, that you can come back into the outpatient clinic to be seen. So instead of the doctor coming to you in your room in the hospital, you'll be coming to the clinic to see the doctor. And typically for these complex allogeneic transplants, the center asks you to remain living close by for those first 100 days after transplant. So you might be in the hospital for 2 to 3 or even 4 weeks. And so then an additional couple of months after discharge. You'll continue to have ongoing care, and gradually your transplant team working with your doctor back in your community will make the transition back to your community physician for ongoing care, and then have planned follow-up back at the transplant center as needed. So on the next slide, well, let's talk a little bit about, well, how do I know this transplant is going to work? Dr. Khera mentioned a potential cure. I want the cure. So in general, we think that transplants are most successful if the smallest amount of disease is present when you go into the transplant. And so we try to think about remission. So sometimes we'll give some therapy before transplant to try to kind of beat that MDS back down. And we really want to get to a transplant before it's evolved or transformed into that acute blood disorder, leukemia. We mentioned that we want to make sure your organs, your lung, heart, kidneys, everything is working well, that you're physically strong, no infections, and really importantly, is that this is a difficult procedure. And not only is it difficult for the patient, but you're really going to need your help and support from family and friends. And I know they will rally around you, but that is something that you can prepare for before transplant, about who will help you during that long process. On the next slide, here are some tips for how you might improve your chances for a better outcome, and how you can work with your doctors and your team. So there's never a silly question, and you might have to ask these questions several times. I know that when my patients are in, this is a stressful situation, that it's really good to have someone with you to take notes, and so that you can ask questions, revisit your notes, ask the doctors, ask the advanced practice professionals, the physician's assistants, the nurses. Ask questions about what is the best for you, what are the possible risks, and whether or not this really is the right choice for you. You might want to visit more than one transplant center to get another opinion and to see where you're comfortable at. One thing to think about is that since you're going to need to live locally, that usually means within about a 20 to 30-minute drive maximum to the transplant center. Each center has their own guidelines. Think about that, about how far is that from your home, and how that would affect your ability to have friends or family stay with you. Importantly, when you're so stressed and worried about yourself, think about your physical and mental health. Try to stay active. Try to eat well, avoid alcohol and tobacco. And some patients ask me, well, I've smoked all my life, is it too late to quit? And I would say, no, it's never too late to quit, because even if you can stop when you're preparing for the transplant, that will help your lung function. Think about your caregivers, not only family members, but friends. Everyone wants to help. Please let them help, because they want to do what they can for you. And often that can be a rotation of different family or friends that can come and stay with you for a few days or for a week, but plan that in advance. And as Dr. Khera mentioned, this is an expensive procedure. Social workers at transplant centers are very good. Many of the centers have a financial office that can really help you plan, but not only for coverage of transplant, but tell you if you have coverage for medications, but also think about housing, travel, time off of work for your caregiver. Those are all financial issues that if you can plan, it will help remove stress and have you have a path forward. So next slide. What about if you're the caregiver? Well, think about three main areas. I think it helps to just kind of compartmentalize. First thing is be that person that goes and helps gather the information, ask the questions, perhaps that you know that your patient wants to ask, but maybe is a little frightened to ask. Talk to doctors, ask the questions, ask them again if needed, help care for the patient. That may mean putting out the pills on a weekly basis, checking to make sure that the refills are being handled, helping talk to the insurance company and manage the financial issues, and importantly, listen and support your patient. But as you know, that also takes an emotional strength from you. And so take care of yourself. There are so many resources. Over the past few years, we've come to understand that we need to support the caregivers who support patients. The MDS has wonderful programs for both patients and for caregivers. So to Be the Match, other society foundations, talk with your transplant centers, talk with your local hematologists and social workers. They can all really be great resources for you to plan to support yourself. The next slide talks about what we can do. This shouldn't be all on our patients and caregivers. I would urge all providers, that means not only physicians, but nurses, nutritionists, physical therapists, clinic staff, help provide education about all the treatment options. So transplant may not be right for everyone, but partner together, work together to help the patient seek early referral, to talk about options, prepare for financial coverage, help support the patients through the mental and physical aspects to reduce risk of transplant, and really be a partner to support that patient in all aspects of their care, assist in the social support. And importantly, I really think it's on us to work very, very hard through all of our research organizations to develop clinical studies and trials and improve the treatment approaches through research. The next slide, I just want to tell you a few take-home points. We've given you a lot of information today, and so we thought we would just kind of summarize that to think about transplant, if you have what's called higher risk MDS, and if you're healthy and strong enough to have the transplant. But think about getting to that transplant center early on when you're diagnosed. Speak with your diagnosing physician and plan ahead, because there's lots of steps for both pre and post-transplant care. And I think if you plan, you feel more in control of the situation, and it's less likely that anything will go on during the course, so that you and your family and your caregivers really have the best possible care. So thank you for that. I hope this has provided you some information. On the next slide, I think that Dr. Khera is going to have some questions for me.
Thank you, Dr. Burns, for a very informative presentation. I'm sure our patients learned a lot from it, and caregivers too. Just a few questions to clarify some of the things. So can patients refer themselves to a transplant center, or do they need their doctor to make the referral?
Yeah, that's a great question. Patients can refer themselves. You can refer yourselves to a transplant center, and how you would do that would be simply calling. If you take a look, on every transplant center has websites. The National Marrow Donor Program also has a website, Be the Match, that has contact information, who the medical directors are at all the transplant centers. But it really helps, and I would recommend that the process will be much easier if your doctor makes the referral. Because when you're seen at the transplant center, they're going to need to have all the medical information about your case, and that may also mean to have the pathology slides, or if you had a bone marrow examination, if you had x-rays done, that really would be most beneficial. And then the transplant team can speak with your doctor back in the community and work together. That really is the best approach. But if there are any issues, or you want to see a specific transplant center, certainly you can make your own referral.
Thank you. So as we talked about, this is a very complicated procedure, both from a medical and logistical standpoint. Do you think, is a patient ever too old or too sick to have a transplant? And then who should make that determination? Should it be the patient's hematologist or the transplant team?
Yeah, that's really a great question. As we mentioned, over the past 10 to 20 years, there's been so many advances in transplantation. When I started transplanting, I did my first transplant actually in 1984. The upper age limit was 45. And now many transplant centers do not have an upper age limit. So age alone should not be the only factor to think about. But of course, we do know as we age that our bodies are not as strong and that our heart, lung, kidneys may not be as healthy. So even though we have these newer ways of doing transplantation for patients that are older or maybe have diseases such as diabetes or hypertension, that unfortunately it means that there are patients that are not healthy enough to have a transplant. The transplant center really is the best to make that decision because they understand best. This is a very specialized field about what a patient will need to undergo for that transplant. So that, again, is why early referral is important. There's also many times where we can't make you younger, but we might be able to make you healthier. And there are ways that if we are able to identify some what we call morbidities, maybe some physical rehabilitation, maybe better control of hypertension or diabetes can make a patient more likely to have a safe outcome with a transplant. So again, it's that early referral. But not everyone, unfortunately, will be able to have a transplant, but then there's non-transplant options that Dr. Khera mentioned. There's been a lot of advances in the non-transplant field. So again, shared decision-making is so important.
Thank you. So we talked about the distance. Most transplant centers would want patients to be living 30 minutes to an hour away from the center. But other than the distance, what are some of the other things that a patient should think about when choosing a transplant center to go to?
Yeah, I think there are things that you can do to see if you have a really good comfort level with that transplant center. A couple of tips are to ask what the experience has been at that transplant center. Do they see patients with your disease frequently? Do they care for patients with your disease? And what have been the outcomes of those patients that have undergone transplant center? So patients like yourself. I also think that it can be helpful to think about, is it urban or rural? That do you feel comfortable living in that setting for several months or 100 days after the transplant? The other things are to really just, when you visit the center, many of the centers will show you their facilities and the clinics and just see how it feels to you. And one last thing is that you're going to need care for a long time after transplant. We call those care for a long time after transplant. We call those transplant survivors, right? We hope that you live a long time and you're cured of your disease. And many transplant centers have developed survivorship clinics that provide specialized care for patients who have been cured from their transplant. So that's another important thing that I would ask the center. Do you have survivorship care? And how closely would you work with my community physician? Do you have telehealth options? I wouldn't have to travel back and forth so much. So those are other things to think about.
I think those are really great points. So thank you so much for your portion of the talk. And I would like to thank all of you patients who participate in the clinical studies, the families, caregivers who help us make work in this area to try and do more research and improve our outcomes for our patients. Special thank you to the Aplastic Anemia MDS Foundation for inviting us to share this research. Also, thank you to the CIBMTR, our BMT Clinical Trials Network, the National Mayo Donor Program, and finally, our Evidence into Practice Task Force at the BMT CTN. With that, we would end. Thank you so much.
Thank you.